So, hello everyone. I hope that you can hear me. I am Dragana Panic, a journal relations specialist for JCM Journal, and I want to thank you for joining this webinar that is organized on behalf of our journal. So before we start with this webinar, I would like to share my screen and say a few things. So MDPI is a pioneer in scholarly open access publishing, and we have supported academic communities since 1996. Our headquarters is in Basel in Switzerland, and we have the mission to foster open scientific exchange in all forms across all disciplines. We have 422 diverse and open access journals that include 430 peer-reviewed and 9 conference journals, and we are supported by more than 150,000 academic experts who share our mission with us, values, and commitment to provide high-quality services for our authors. When it comes to JCM, we are international peer-reviewed open access journal of clinical medicine that is published semi-monthly online by MDPI. Our current impact factor is 3.0 and our site score is 5.7. We have 2 editor-in-chiefs and more than 2,000 editorial board members that help us out to develop the journal and to monitor peer review process. So the program of the Diabetic Food Management latest breakthroughs and best practices webinar will be the following. We will start with a brief introduction of our chair webinars, and then we will have 4 speakers, Professor Siko Bass, Dr. Venno Kavartapu, Dr. Marco Meloni, Dr. David Armstrong. We made an agreement that after each speaker, we will have a Q&A session. So I hope that this will be a good way to continue the discussion after each presentation. Then Professor Luigi will close the webinar. Also, if you are interested to submit your research work that is linked to this topic, we encourage you to submit your research to a 3rd edition of the special issue Diabetic Food Complications that is led by our webinar chairs, Professor Luigi Uccioli and Professor Jose Luis Lazaro Martinez. And also I would like to remind you that you can ask questions in Q&A box that is located at the bottom of your screen. And please make sure that you write the name of the person that you intend to ask and that you address the question to. Now I would like to hand over the word to our webinar chairs, and I believe that we can start with our webinar.
Thank you so much, and good afternoon, everyone. For me, it's a real pleasure to chair this webinar beside my co-chair, Professor Luigi Uccioli. We had this afternoon a very interesting webinar with, I think, 4-star speakers. I can say that for some of them, there is not necessary to mass introduction because they are a very well-known scientific, there are a very well-known keyholes in the field of diabetic food. So let me introduce before to start the webinar with my co-chair, that is Professor Luigi Uccioli. Professor Luigi Uccioli is a long-term scientific in the field of the diabetic food. Currently, he is the director of the endocrinology and diabetology section of CTO Hospital in Roma. But for a long time ago, he was joining Tor Vergata University, and he has a lot of experience with publication and researches in diabetic food. So he was a pioneer in the diabetic food field, and he has a lot of awards and a lot of roles in the managing and chairing different organizations. Along that, I think one of the most important is that he was the chairman of the Italian study group. At the same time, he was the chairman of the Diabetic Food Study Group is an association that is inside the European Association of Study Diabetes. And recently, in 2022, he was awarded for the DFSD Lifetime Achievement Award. So this is a real pleasure to share with Professor Luigi Uccioli this webinar.
Thank you.
Where is you're welcome.
Thank you, and want to say that probably I have to present also Jose Luis, that is a close friend, but he has so many titles and so many responsibilities that probably with the time that we have so short in the webinar, we have no time to list everything. Everything in any case, Lazzaro, José Luis Lazzaro Martinez is a professor at the Complutense University in Madrid, and he's chairman of the DFSG, and he is going to have additional responsibilities. And I'm happy to share with him this webinar. I want to thank JCM for this opportunity and the opportunity to have this speaker very, very important and very relevant in the panorama of diabetic food. So I think that now we have time to start.
Thank you, Professor Riccioli. Thank you. You are very kind. So we are going to introduce each speaker just to remind for the attendees that we are planning to do the Q&A after each presentation. So I ask the people to send the question after each presentation for keeping related with the last topic that the presenter did, right? So the first presentation is going to do by Sikobas. So Professor Sikobas is a professor in the Netherlands in the Department of Rehabilitation Medicine of the University of Amsterdam. So I think that he doesn't need too much presentation because he's very well known, and I can say one of the most knowing person about the biomechanic, about all the researches in offloading in diabetic food. And he's going to introduce us with a presentation about the new approaches for offloading diabetic food and increase ulcer-free day survival. So thank you, Professor Sikobas. The floor is yours.
Always good to see that when a webinar starts that technically things are going the right way. So thank you very much, José Luis, for this kind introduction, and also for the invitation to speak on the topic of offloading and how to increase ulcer-free day survival in people who have diabetes and are at risk of developing foot ulcers. And I will discuss in the next 20 minutes some approaches based on some recent data that we collected for offloading the diabetic foot and also for increasing this ulcer-free day survival. So when it comes to development of foot ulcers, apart from a purely vascular pathway where there's necrosis because of the vascular compromise, which can result in a foot ulcer, pretty much all foot ulcers have a mechanical pathway. So there's mechanical factors that determine whether a foot ulcer develops or not. And it starts with diabetes and the complication of neuropathy, where each of the neuropathic systems are affected. So the sensory neuropathy leading to loss of protective sensation, and motor neuropathy leading to atrophy and deformities and biomechanical abnormalities, and also autonomic neuropathy leading to dysfunction and dry skin. And then in the mechanical pathway, there's pretty much three options. So there can be continuous stress at relatively low level, for example, from ill-fitting shoes that can determine that a foot ulcer develops. Or there's repetitive stress at a moderate level, which is mainly from the fact that we are weight-bearing, patients are weight-bearing, and can then develop into callus formation and foot ulcer development, and also high stress from direct mechanical trauma, for example, from a little stone that is inside the shoe, or patients going barefoot and then stepping in some kind of foreign object. And here it's depicted a little bit more graphically, where this most common mechanism of repetitive stress is shown, where because of the abnormal pressure being applied repetitively during the day from all the weight bearing that we do, there's callus formation, and from the inflammation and further minor trauma going on from the impact, hemorrhage develops underneath that callus, and when the callus is removed, then the skin breakdown shows through the dermis and the epidermis, which then, of course, results in a foot ulcer. And this mechanical pathway of foot ulceration, we have studied in Amsterdam very recently. So a PhD student of mine, Chantal Hulshoff, has worked on this mechanical pathway where we found that in the literature, of course, high peak pressures, high stresses underneath the foot have been measured and have also been associated with the development of foot ulcers, but the predictive value is not necessarily that strong, likely because there's many factors that will determine, apart from just the normal peak pressures on the foot, that a foot ulcer will develop. And we try to estimate what we call the cumulative plantar tissue stress on the foot. So based on the fact that patients are weight-bearing and they have a certain number of steps that they take during the day, they wear footwear, they go without footwear or may wear slippers, which is also, of course, affecting the biomechanical situation, and they have barefoot pressures and in-shoe pressures. So that's all contained in this cumulative plantar tissue stress. And we found in this observational prospective study that the cumulative plantar tissue stress was not directly related to the development of plantar foot ulcer, but it was indirectly through the mechanism that I just explained with this pre-ulcer development. So callus and pre-ulcerative lesions like hemorrhage or a blister developing, and the cumulative plantar tissue stress being strongly associated with these pre-ulcers, and then the pre-ulcers being strong predictors in this one-year follow-up study for plantar foot ulceration. And that confirms previous research that has been done that also shows that these pre-ulcerative lesions are a very strong predictor to foot ulceration. And in this study, we could also find that walking speed is the second or the other strong predictor of plantar foot ulceration. So quite easily to obtain clinical parameters that determine that a foot ulcer develops, or at least are very strong predictors, and the mechanical pathway that I just explained through pre-ulcerative lesions also being confirmed here. So when it comes to offloading, it has already a long tradition in treating and in preventing diabetes-related foot ulcers. I could say that offloading is the most important aspect of treatment to heal diabetes-related neuropathic foot ulcers, but it's still important when it comes to healing complicated diabetic-related foot ulcers, such as with ischemia and with infection. And arguably, offloading is the most important aspect of treatment to prevent diabetes-related plantar foot ulcers. And that is also shown by this graph, which is a common graph that I use in presentations, and was in a publication with Professor Armstrong and also Professor Boulton, that shows on the right-hand side, on the x-axis, the follow-up years after healing of a foot ulcer, and on the y-axis, the incidence rate, showing all prospective follow-up studies that we could identify that assessed patients for re-ulceration, as we would say, over time. And if you draw a trend line through all those studies, you see that already within 1 year, 40% of patients re-ulcerate who have healed from a foot ulcer. And this increases to 60% in 3 years and even further over time. So a very important problem from the moment that we heal. So it's not just about healing a foot ulcer and using offloading for that, but also the fact that there's a very high risk of re-ulcerating in these patients. And of course, adequate treatment is needed there. The International Working Group on Diabetic Foot has guidelines on the prevention of foot ulcer that are updated every 4 years. And in 2023, the most recent one came out, and there's 5 key elements of prevention. And here in red, I show the ones where the offloading plays in a role. So ensuring routine wearing of appropriate footwear, and also treating risk factors for ulceration, which could be, for example, a deformity and a surgical intervention that I will discuss. So particularly, and that's a recommendation within the guidelines that is based on some very clear clinical evidence from randomized controlled trials. When it comes to the patients that I just discussed who have healed from a plantar foot ulcer, the recommendation is strong to provide therapeutic footwear that has a demonstrated plantar pressure relieving effect. So an offloading effect during the walking and the standing that these patients do to help prevent a recurrent plantar foot ulcer from occurring. And of course, it is important because a very good shoe cannot be effective if it's not worn. It is important to encourage the person to consistently wear this prescribed footwear. And both indoors and outdoors, and the guideline also has some indications for what we mean with demonstrated plantar pressure relieving effect. When it comes to surgical intervention, one of the new recommendations that we now have, based on recent RCTs on surgical intervention of flexor tendon tenotomy, is in a person who has diabetes and who's at risk of foot ulceration, who has non-rigid hammer toes, has excess callus or a pre-ulcerative lesion on the apex of the distal part of the toe, is to consider digital flexor tenotomy for treating these outcomes. So also a surgical offloading technique in non-rigid hammer toes that are hammering on the ground, where you would see, if you would do pressure measurements, you would see an increase in pressure underneath the apex of the toe, where digital flexor tendon tenotomy can straighten the toes and reduce the pressure underneath that apex. And the RCT shows a significant reduction of the risk of recurrence compared to conservative or at least non-surgical treatment. So going back to the footwear, the biomechanical effect that we find by the footwear is very well known. There's a lot of elements, design elements in a shoe that you can apply, that you can use. For example, a rocker outsole, where we already know quite long what the pressure relieving effect is. Custom-made insoles we have done already, and others studies over the last 2 decades about the pressure relief, also specific elements in these insoles. And more recently, we found that a particular 6 millimeter thick top cover of the insole with an open cell and a closed cell foam construction provides more pressure relief than not having such a 6 millimeter thick top cover or just a 3 millimeter thick top cover. So the top cover is also an important aspect for providing pressure relief over pretty much all the regions in the foot. And also the bending stiffness of the outsole is something that we did some research on lately that shows that increasing the bending stiffness gives you about a 10 to 17% relief in peak pressure compared to having lower bending stiffness. And all this biomechanical knowledge that we have about footwear can be entered in what we call a state-of-the-art footwear design algorithm that we developed with a team of multidisciplinary team of rehab physicians and shoe technicians or orthotists or podorthists, as you call them, and also scientists to base on the evidence that we have in terms of the effect of different footwear designs on the pressure, or the ones that we know from clinical evidence, what footwear can do in a diabetic patient, mainly who has a foot deformity, where based on the specific domain of the foot, which is mainly a foot that has neuropathy and has some type of deformity, you can define based on the evidence, and if the evidence is not available, based on consensus, what the different shoe construction elements should be and are recommended for that particular domain, so for that particular deformity. And more specifically, looking at the pressure relief, we came up using this scientific evidence that we have on a 10-step approach to pressure relief. So a 10-step algorithm to provide evidence-based pressure relief. And if you look at these different construction aspects for the shoe and the insole, what is now visible compared to probably what we know from years ago is that it's much more quantitative. We have much more quantitative evidence about what kind of design elements to put in a shoe, where the more traditional approach to footwear design is based on skills and also the experience of the technician and the physician. So just as an example, you see here that for the shoe and the rigid outsole or the rocker outsole that we have, there are specific bending stiffnesses or degrees or specific angles that are applied for such a footwear design. And also for the insole, you see particular thicknesses and locations for where a transmetatarsal bar is located proximal to the metatarsal heads that you want to offload, and also information on the thickness of a top cover that we did this research on. And then in this 10-step approach, in-shoe plantar pressure measurements are added to evaluate whether the footwear is offloading appropriately, and if not, and we use indications of 200 kilopascal, if the pressures are still above that level of pressure, further modifications can take place to provide an improved footwear situation, and then these pressures are reassessed over time. And using such a model, such an algorithm in footwear design, we found in experimental research that we did that when you incorporate such an algorithm in a fully custom-made shoe or in a custom-made insert that you provide, that you put in a diabetes-specific off-the-shelf shoe, which is the shoe A and the insole A concepts, and you compare that to some other quantitative and pressure-driven insole concepts that have been published, we see that looking at these percentages, which are the percentages of cases that we find where the in-shoe peak pressure that we measure is below 200 kilopascal, we see a much higher percentage in these shoe A and insole A for particular regions where foot ulcer often develops. So close to 100%, 90% to 98% compared to the other data-driven concepts. So we also have evidence that such a quantitative, data-driven pressure approach is effective in offloading and in providing improved and maybe close to optimized footwear. Studying this in randomized clinical trials, we have a Dutch study that was done a little bit more than 10 years ago, also a US multi-center trial done about 10 years ago, and we have the Spanish trial where Jose Luis was involved in, that was more recent, where each of these trials show that when you have a shoe that effectively reduces the pressure, and you have indications that these shoes are worn as recommended, it significantly reduces the risk of developing a foot ulcer recurrence in high-risk patients with diabetes and neuropathy and foot deformity present. So about a 50 to 60% reduction in the risk of recurrence can be achieved. Now, one aspect that I mentioned about this footwear is, and also that is incorporated in the guidelines, is that the footwear should be worn as recommended. And we know from the literature and from studies that we also did is that these footwear, even though they can be appropriate, are not always worn and not worn as recommended. So we found that even in very high-risk patients who have just healed from a foot ulcer, have deformity present, that about half of these patients do not wear their footwear as recommended, where we mean with as recommended that at least 80% of the steps that they take, the prescribed footwear is worn. And particularly when patients are inside the house, they have lower adherence while they are more active inside the house, so they take more steps compared to being outside of the house. And in particular, in these early morning hours and night hours, and also the late evening hours, we see that the adherence is lower. So it's really mainly an in-house problem where patients take off their shoes and they go about barefoot or wearing other type of footwear. So this sort of stimulated us to see if we could develop, again with a multidisciplinary team of physicians and technicians and scientists, a specific custom-made shoe that is designed for use indoors, and you see an example on the right-hand side, that still meets quality standards, for example, in terms of pressure relief, because it will be used as a replacement for the prescribed shoes that are recommended to use, and would hopefully result in increased adherence at home, because the design is focused on the home situation, where patients, when you ask them, why don't you wear your custom-made shoes inside the house, they say, well, they're too heavy, they're dirty, they're difficult to take off and to put on, etc. So we use that as an input to these new developed in-house shoes to make them more breathable, lighter weight, easy to put on and take off, and to then see, okay, will this improve the adherence in particular inside the house? Like I said, they have to meet quality standards. So in terms of their pressure relief, they would have to be similar to the custom-made shoe. And we showed in this group of 30 patients that that was at least the case. So for different regions, the pressures were very comparable. And then looking at the adherence, we found that from a baseline adherence in this patient group of about 60%, we saw a significant increase in the adherence in 1 month time. But of course, you don't only want to assess this on the short term, also on the long term. So we assessed again adherence, and we used for that a sensor inside the shoe at 12 months. And we found that the adherence even further increased to about 85%. And we found particularly, of course, the effect inside the house. So inside the house, patients went from about 45% of adherence at baseline to about 70% after 1 month, and about 80% adherence just indoors with having such a specific custom-made shoe for indoor use. And if you look at the outdoor adherence, you see that it's already high at baseline. So the adherence issue is not really an issue when patients go outside the house. And of course, this stayed quite stable over time. So sort of to wrap up, if we look at a state-of-the-art personalized approach to footwear, we say it's systematic. So it uses a set of rules for the design, which is quite quantitative. It's science-based, so we have a lot of scientific studies in the literature that will help you to determine, what is an effective shoe for a particular domain or deformity in these patients. It's data-driven, so we do assessment of foot shape using scanners. There's pressure measurement and other data that you can use to drive the design and also evaluate the footwear. And it's evidence-based, as I showed from the trials that have been done, that having a shoe that is improved in terms of its pressure relieving properties and worn as recommended, that you can find a substantial reduction in the risk of ulcer recurrence. So with that, we're moving over time to how prevention is really sort of organized from stratified healthcare, where you have these different risk strata of low risk and moderate risk and high risk, where you have some general treatment approaches, even though there's customization going on, to a much more personalized data-driven approach where we measure a lot more in these patients. And I gave some examples about the pressure, about the weight-bearing activity, about the adherence of their footwear. But it could also be personalization in other respects, where for one, a particular shoe works very well, but for other, maybe the surgical offloading intervention would be best given the type of deformity and the particular context that the patient is living in, to eventually come to the right treatment at the right time for the right patient. So with that, I would like to close, and of course, very open to questions. Thank you.
Thank you, Professor Baas, for your nice presentation. I think you never always disappoint with your presentation, because you can offer every time that you speak a new insight about biomechanics. So remember that you can do the question in the box, that you have a question and answer box in the menu at the bottom or in the app, depending on the Zoom settings, right? So I took some questions during your presentation that the attendees did. So one of them is something that probably is very concerning for the clinical point of view, and is one question in two, right? The first question is something that the people used to ask very frequently. It is possible to recommend any physical activity for the patient when the patient has the active ulcer? This is the first question. And the second one, when the patient has the ulcer healed, how long can walk? So that means how we can give the patient a recommendation about to walk in a septic, I think time, or in a septic model, in order to avoid any recurrences.
Yeah. So physical activity is a very important component. of course, of the biomechanics and also related to the to clinical outcome. And it's something that is still providing us a lot of questions, because if you look at the literature, some studies show that the more active patients are, the lower their risk of developing a foot ulcer. Some show the opposite, and also related to the active stage where you actually have an ulcer, we see that there's different outcomes from different studies. So it's still difficult to grasp really what the influence is of the activity. But I think also if you look at studies from different regions in the world, you see that in some regions patients are much more active than in other regions, without necessarily showing worse results in terms of healing, for example, of foot ulcer. So apparently there is a possibility to be active and not to limit the activity of the patients when they have a foot ulcer. So I don't see real evidence for prescribing that and for limiting. Of course, it's very important to provide good offloading and to make sure that the offloading device that they get is worn. And then they can be quite active. And so the activity aspect, and in the prevention guideline, we actually have a recommendation on this, because looking at the literature, we found that even if you tell patients that they can be more active, and we classified that as taking about 1,000 steps more per day, and for some patients that's quite a lot, it's still safe in terms of the development of foot ulcers. So we actually have recommendations on physical activity, but it's still providing us with a lot of questions about what the exact role of the activity is in terms of healing and development.
And for the second question, that is regarding how the activity could be saved or can be saved after the ulcer healing in order to avoid recurrences. Is there any protocol that the people can adopt for saying the patient, okay, you can walk 100 meters, you can go 1 kilometer. It's a question of the distance, it's a question of the amount of activity in one day, it's a question of the speed. So what do you think about this?
Well, what we only really know is the number of steps. So the number of steps is the activity measure that we know most about. When it comes to speed, when it comes to like bouts of exercise or activity, like should you put all your activity in one bout, or should you be distributed over the day? That has been looked at, but it doesn't lead to a very consistent outcome that let's say reducing the variability in your activity over the day will benefit you, because other studies show that it's not the case. So multiple thousand steps are possible in terms of activity when you've healed from a foot ulcer, but I don't see any reason for when you have a foot ulcer to do that differently. And like I said, in the recommendation is that if you increase that number with 1,000 steps, it's still showing to be safe. In terms of information about speed, well, what we showed in our risk model is that the lower the speed, the higher the risk of developing a foot ulceration. Now, of course, that indicates not along the way of the cumulative stress on the foot, because you would expect it to be lower with a lower speed, but probably because of its association with other factors that may have to do with frailty and aspects of the disease that are related to the fact that the patient is walking slower will influence the outcome. But I mean, if you can train patients and develop a better or a higher walking speed, it may eventually end up being a protective factor to foot ulceration.
Thank you. Thank you. I think that unfortunately we don't have more time for discussing. We can spend with you 1 day or 2 days talking about different aspects in this specific topic that is quite important for the managing of diabetic foot. Thank you for joining. Thank you again for all your investigation or research and
Sorry, I cannot find that one, please. Yeah, okay.
Thank you.
Thank you. So I'm going to introduce the next speaker, and at the same time, I will invite Professor Riccioli to share the questions coming from Dr. Kavartapu. So Dr. Beno Kavartapu is a consultant orthopedic surgeon. Is working in King's College in London. King's College, I can say that is more or less the one of the main center managing with diabetic food in the world. He's an expert in the Charcot food in general, but especially is an expert in managing patients who need a Charcot food reconstruction. He was the president of the International Association of Diabetic Food Surgeons, and is a past member of the Charcot International Consensus Committee in 2023. So Dr. Kavartapu has a long experience with managing this kind of patient, very challenging patient, that unfortunately in some place of the world, the only indication that they are receiving is the lower limb amputation. So it's a real honor for us having you, Dr. Kavartapu, and now the floor is yours.
Thank you very much, Jose, for this kind invitation and your kind introduction. And thank you, Professor Riccioli, for participation in this amazing event. So this topic on we're going to discuss the evidences on Charcot foot reconstruction and the major amputations as well. And we are hoping to define where the border could be. Well, it is quite an evolving topic, because we don't know completely about this evolving concept of Charcot foot as yet. Even though it was described more than 150 years ago as a condition that results in bone damage in those people that have peripheral neuropathy related to tabes dorsalis, but it was not until 70 years later when Jordan identified that there was a direct association with diabetes and Charcot neuropathy. From the treatment point of view, it was not until Paul Brandt recognized a direct link to the inflammation component, heat and pressure, and hence he introduced the total contact cost treatment concept, which has remained the gold standard since then. But around the same time in 1966, Eichenholz described the radiological progression of acute Charcot neuropathy. And very interestingly, around that time, a surgeon from the US, Johnson, reported the association of fractures with Charcot neuropathy, and they also, in very much detail, reported the outcome of any surgical interventions. We really value the contribution from Shibita in identifying stage 0 Charcot neuropathy, which has more or less revolutionized our ability to prevent major complications following an acute Charcot. And of course, on the medical side, there have been recent and significant improvements due to our better understanding on the pathomechanics, but that area hasn't really advanced as rapidly as we had hoped. But I would like to observe all of us this aspect of this study done by Johnson's team. One of the first large series presentations of 118 foot fractures among people with peripheral neuropathy. They were recognized as Charcot, but majority of these did not respond well to surgical intervention. And in fact, that experience has also led to the view that surgical intervention is perhaps not a safe thing to do. Maybe an amputation could be a safer option. So this Charcot foot typically presents as an unexplained, painless, hot and warm, swollen foot and ankle, often with a history of minor trauma, and the temperature difference is usually more than 2 degrees. And if you examine these patients carefully, you always find an evidence of small fiber neuropathy, but it can be very profound sensory neuropathy too. And depending on the stage of the presentation, there can be significant bone fragmentation that manifests in terms of crepitus and deformity as well. And they can ulcerate, which can get infected, and that can lead to an amputation. But majority of these presentations are managed with offloading. We had, fantastic talk earlier, covering all aspects of that. But despite these measures, a significant proportion of these patients will develop ulceration and infection and limb loss. And in fact, some studies have shown that up to 50% of patients with Charcot foot require at least one operation on the affected foot in their lifetime. And if they develop ulceration and infection, it carries an amputation, very, very high rate. And in fact, we have one of the key researchers in this area, Dr. Armstrong, who will perhaps take us through in a bit more detail. But the point here is that a mere diagnosis of Charcot can carry a high risk of amputation, about 30%. But a major amputation carries a 5-year mortality of almost 65 to 70%. And that is what we are trying to compare with. Well, a Charcot foot with a limb risk scenario, should it be reconstructed or should it be amputated? Well, in general, the Charcot foot management has remained very, very difficult until the role of a multidisciplinary component was introduced by Professor Mike Edmonds and the team leader of King's Diabetic Foot Unit, who first introduced such service about 42 years ago and identified a remarkable improvement in the patient outcomes so that it was at that time recommended as the WHO standard of care. What we have observed in our unit when our other diabetology colleague, Dr. Chris Manu, reviewed all our amputation rates over a long period of time was that in this graph, you can see the reduction in our amputation rates from 1990 to more recently, and there has been a steady reduction in amputation rates. And those big dips happened when the far distal, ultra-distal revascularization was introduced. And the second dip was when the Charcot reconstruction service was introduced when I joined the team. So, but we still don't know fully about the expectations following an amputation or a Charcot foot reconstructions fully. But let's examine the evidence that we have in front of us. But by and large, when we aim to reconstruct a Charcot foot, the aim is not just to save that limb, but you need to retain the function. It has to be a functional limb salvage. So that can be a simple deformed Charcot foot with an intact skin, or it can be more complicated with an ulcerated or infected, or it can be even more severe presentation, which is an actively infected Charcot foot, which has been traditionally considered as a serious limb threatening. The expertise and perhaps the size of that multidisciplinary team that manages such presentations should match the degree of that pathology. So clearly, a deformed and actively infected Charcot foot should be managed in big centers where there is such a large expertise is available. So these are perhaps 5 categories. In our unit, we use when a Charcot foot presentation is there, a simple hindfoot or midfoot Charcot in its perhaps lowest pathology, or a combined hindfoot and midfoot Charcot, a bit more complex in terms of surgical treatment, or an acute progressively deforming Charcot foot, the foot at risk acute Charcot is much higher pathology. A Charcot foot with an active infection, whether an actively infected ulcer with deep penetration or deep bone infection, or finally severely ischemic Charcot foot. And these are all the kind of presentations that lead to amputations. Let's observe these in general. So if you look at the evidence on Charcot foot reconstructions, well, recently we have observed the evidence over a decade. But what it has shown that, the reconstruction that it utilized internal, external fixations or even combined techniques more recently, they have showed similar results, but no clear statistical evidence of one better than the other. But overall, there has been a progressive improvement in patient outcomes. And we have also done another more detailed systematic review in 2020, looking at, again, different components of Charcot foot reconstruction using external fixation and internal fixation. So as an example, the bone fusion rate with external fixation was found to be 94%, and with internal fixation, 81%. That was far, far, far better than previously felt, certainly far better than what Johnson's team had identified more than 50 years ago. Now, full weight bearing was achieved between external and internal fixation between 19 to 16 weeks. The amputation rates following surgery was between 4.6 to 4.9%. And this is far better compared to what was actually achieved a few decades earlier. But I would like to focus more on the internal fixation aspect, because that is where we have gained a lot more experience. But the principle of the internal fixation should follow this dogma. It has to be a durable, long segment, rigid internal fixation with optimal bone opposition. And we identified this component of the fixation principle when we assessed a series of midfoot Charcot reconstructions more than 10 years ago. But however, since that experience, we've been following this surgical treatment principle. So by and large, the fixation using internal fixation, Charcot foot reconstruction, I'm going to describe, will be using these principles. So let's discuss about the least concerning Charcot foot presentation pathologies, isolated midfoot or hindfoot Charcot. So if it's an isolated midfoot Charcot, many centers, including our team, have observed that depending on the deformity patterns, one has to use appropriate surgical approaches. And we should always achieve soft tissue balance. And by performing wedge or rhomboid resections, we can correct the deformity. And then we fix that correction by using this long segment rigid internal fixation principle I have enumerated earlier. And with such principles, the fixation outcomes are far better. But however, one has to use a tailored approach to that presentation, because the fixation principles I have mentioned earlier were just in relation to the deformity characteristics. But there are multidimensional presentations. So if you look at this 53-year-old type 2 diabetes patient with a rocker deformity, but if you observe more, the lateral column is not significantly deformed. It is a medial column isolated midfoot Charcot disease. And the vascular studies in this patient have shown a kind of suboptimal or poor lateral aneurysm. So we, in our unit, target only the deceased or deformed midfoot Charcot component. And here in this patient, it is just the medial column. So the lateral column was not actively involved in the disease, and that slight deformity could be easily corrected by using an isolated medial column. In that way, we don't risk developing any vascular complications. So it has to be a tailored approach on all such presentations. Whereas a slightly more complex midfoot Charcot, where both the medial and lateral columns are affected, but the subtalar is not. Again, one can fuse the subtalar as well if there is any deformity or affection, but otherwise we don't routinely fuse. So in this patient, again, there has not been any ulcer recurrence for the past 7 years. When it comes to the hindfoot, which is in terms of outcomes slightly more complex, as it was considered in the past. But however, the fixation principles are very, very straightforward. This 74-year-old type 2 diabetes who had an ultradistal bypass surgery, and within a few weeks, he developed an acute Charcot. The picture on the left side of your screen shows the ankle X-ray done soon after the vascular procedure, but within a few weeks. And this is not an uncommon phenomenon. When the circulation increases, the foot can remain vulnerable to acute Charcot. And of course, by the time patient came for surgery, due to persistent lateral loading, it already developed lateral column osteomyelitis. So, but however, this is purely a hindfoot deformity. So an isolated hindfoot Charcot reconstruction using an intramedullary hindfoot nail is the gold standard if you choose to use an internal fixation. We don't favor using plate fixation unless in certain specific situations. You just correct the deformity, line up the ankle and subtalar joint, and apply a compressive hindfoot nail. And on this occasion, used a vascularized fibula graft as well, but it's not always possible in more extreme presentations. And this patient who works in our trust hospital is still working and has as a volunteer and has remained ulcer-free. And we have shared our experience of hindfoot reconstructions. The top paper describes 23 patients, and the second one, larger number, 44 patients over a larger period of time. And again, in both series, 100% limb salvage was achieved initially, but 97% fusion rate at the shorter shorter period. But there was metalwork failure noted in fact, in most Charcot reconstructions, not only the hindfoot, even the midfoot. So the hindfoot Charcot metalwork failure is something we examine in more detail. In fact, we have gone through 74 hindfoot Charcot reconstructions and examined the metalwork failure incidence and any correlation with any technical aspects of the reconstruction. On the left side, you can see the surgical steps most centers routinely use. But when we retain the medial malleus and also used a long enough hindfoot nail that catches the isthmus part, so you get the isthmus fit. And when we also used an additional calcaneotibial nail called a mesonail screw, then the metalwork failure rate was very, very low, only 7%. Again, that is something we did not know before. So there is a lot of progressive evidence coming out on Charcot reconstruction parts. But certainly, a combined hindfoot and midfoot Charcot presentations were considered in the past as an indication for an amputation if they were not be offloadable. But however, in our center, again, we have developed surgical techniques and we have reviewed our results as well. This particular hindfoot, midfoot Charcot presentation with vascular presentation as well. So following vascular optimization, again, you excise all of those previously infected ulcers. These require larger approaches to be able to access all those components of the hindfoot and midfoot. First, correct the ankle joint deformity and then subtalar. Once you correct both of them, achieve compressive nail fusion, and then the residual midfoot deformity can be corrected using osteotomies and then fixed using whatever plates or beams, whatever techniques. But in those days, when this patient had the surgery done, only plate options were available. And again, the patient has been ulcer-free and infection-free for 8 years. Again, if you achieve an optimal deformity correction and if the foot is protected with advanced offloading measures as covered in the previous talk, and the risk of recurrent ulcerations is less in this group of patients. So combined hindfoot and midfoot reconstructions, a series we published in 32 patients. Again, the outcomes were satisfactory. But again, metalwork failure was noted in 8 feet. But certainly, an actively infected Charcot foot presentations are acute progressive deforming Charcot foot presentations were considered as a plausible indications for an amputation. So an acute foot at risk Charcot presentation in this young type 1 patient, severe bone loss with instability, marked shortening. Again, in the active phase, one has to reconstruct because the deformity keeps progressing despite offloading in a total contact cast because of the degree of the bone fragmentation, and this patient has already developed ulceration on the lateral side of the ankle. So such limb-threatening patients, if the ankle is still badly swollen, you need to admit. We admit the patient under supervised leg elevation and non-weight bearing in a cast, and usually within a week, the swelling and warmth reduces so that you can do the reconstruction. On this occasion, both the hindfoot and midfoot were reconstructed. Again, the alignments are regained, and stable bone fusion was achieved. So we have gone through 26 patients with 27 feet that had undergone acute foot at risk acute Charcot reconstructions during stage 1 and 2 of the disease. Stage 1 and 2 with associated instability means the bone deformation or bone fragmentation is so severe that that part remains unstable or wobbly. Preoperative ulcerations were noted in 15 feet. Even in this series, we have noted 100% limb salvage, and full weight bearing was achieved within that follow-up period at 25 months in 25 patients. All preoperative ulcerations had healed. So in our unit, until about 12 years ago, actively infected Charcot reconstructions were initially managed in a frame external fixation, but we had failures even in external fixation, so those were amputated. But however, we have developed a program of reconstruction of these two, but the key ingredients for achieving a successful reconstruction is to eradicate that infection or clear that infection first. You need to achieve the deformity correction and solid bone fusion or stable fibrous union. So that requires a stage reconstruction. So during the first stage, in this case example of a 31-year-old type 1 patient with active deep infection, you debride all of that infected soft tissue and the bone, packed with antibiotic sensitivity specific local antibiotic loaded calcium preparation, and again leave the wound open, apply VAC, and if you achieve radical clearance of that infected tissue and give targeted antibiotic therapy, the C-reactive protein comes down, stays down, the wound healing progresses, swelling comes down, the sugar levels get optimized. Then you can do the reconstruction after usually 6 to 8 weeks, where you correct the deformity, do the final cuts, and achieve that bone fusion. And the patient can commence weight bearing. It usually takes about 6 months for the whole process. So not all patients are keen for such option. But however, in these 22 patients, again, in our series, limb salvage was achieved in all patients. These are self-selected patients because these patients come to us begging for a limb salvage, and they are generally very much involved in the patient care. And again, all ulcers have healed. There were hardware failures, and 6 patients required further surgery, but they haven't lost their limbs. Even severe ischemic Charcot foot deformities that cannot be corrected with advanced vascular revascularization procedures can be considered in selected patients for such new developing treatments. This particular technique called tibial transverse corticotomy transfer, where you make a rectangular corticotomy on the proximal, you can even do in distal tibia, and use a frame to gradually distract about 1 millimeter a day, and that improves the microcirculation. So I have combined that with midfoot reconstruction in the same sitting in this patient that had such severe non-correctable ischemia. Again, once you see adequate transverse distraction, then it is expected that the microcirculation improves. So in this patient, this is the first case, such case we have done in our unit. And I believe the first case for Charcot reconstruction, such treatment was utilized. And we have seen quite abundant callus formation. Maybe some of these severe ischemic Charcot deformities that are routinely amputated may not need such an amputation. We don't know, but this needs to be assessed further. So to summarize, by sharing our experience, we feel that the Charcot foot reconstruction as a subspecialty is rapidly evolving, and more new techniques are coming out with successful outcomes, and the scientific evidence is also consolidating on these techniques. The outcomes are so far progressively improving for reconstructions. So even internal fixation, which was considered as a contraindication in an actively infected presentations, even those show very good results in such presentation. So I feel that the border, which was on far left side towards the amputations, is constantly moving towards the right side following these progressive advancements of these reconstructions. But it will be interesting to see the evolving evidence on this in the coming years to decades. With that, I would like to thank all of you for your attention and thank you for this opportunity.
Dear Benno, thank you for this wonderful presentation and for the wonderful cases that you have shown. I have a couple of questions that came from also our colleagues. One is how much is the amount of infection that you have get with internal fixation? In how many cases you were obliged to remove the internal fixation because of infection?
Good point. Very good point, Professor Chile. So in internal fixations, if there is any metalwork breakage or metalwork prominence, if that cannot be adequately offloaded, we feel that it is better to remove that metal before the patient ulcerates or it gets infected. And that has become more of a common practice in our unit. But despite all these optimal measures, some patients develop infections. Now, if that infection happens following bone fusion, no issue at all. We remove the metalwork. We usually at that time apply local antibiotic-eluting material as well to fill that bone voids, and that provides good and predictable outcomes. But the problem happens if the metalwork gets infected and if there is no stable fusion of those corrected deformity. We probably have we see about maybe 5% of such presentations, and that requires even more advanced and expert multidisciplinary surveys. So even in those patients in our unit, Professor Chile, the outcomes have still been satisfactory, but those patients are subjected to very prolonged, repeated debridements and appropriate antibiotics, but it's a very long drawn-out process. It's still not very clear in our mind where to draw that line of amputation. We always offer amputation to these these higher level presentations, such as actively infected Charcot reconstructions. The discussion starts with an amputation. We recommend an amputation as an option, but those are the ones that are keen to actively involved in their care, very compliant, and those tend to do better.
Okay, thank you very much. Unfortunately, we have not enough time to make all the questions that we should like to. So thank you again.
Perfect.
So
thank you very much. Perfect. Thank you.
So you can present next speaker.
Thank you, thank you, thank you, and thank you very much, Dr. Kavartaku, for the nice presentation. I'm going to introduce the next speaker. That's it, Professor Marco Meloni, who is medical consultant and professor at the University Hospital at Tor Vergata in Rome, in Italy. He is as well the person in charge of the Diabetic Food Service at the same university in Rome. And it's a real pleasure to introduce him, that he's going to talk a very interesting topic that I think this is now in trending. And we are looking forward to see what is the level of the evidence and what is the clinical outcome that these new therapies are giving us a new opportunity for patients with critical limb ischemia. Thank you so much for joining, Professor Meloni, and the floor is yours.
Good evening to everybody. Thank you, Chairman Professor Lazzaro Martinez and Professor Luigi Uccioli for introducing me. It's my pleasure to be here in this board with very important key opinion leaders in the field. Going to my talk, when we speak about the regenerative therapy, it's important to know why we speak about the regenerative therapy. For understanding this concept, it's important to know what kind of a patient we are managing now. Because in the last 2 decades, there is an evolution of a patient with diabetic foot ulcer, with an increase of patients with the ischemic DFU in comparison to neuropathic DFU. And nowadays, more or less 70% of patients with ischemic ulcer are referring to our diabetic foot service. And the ischemic pattern is a very aggressive pattern both from the foot point of view and the general status of view, because they are mainly comorbidities and they are very complex to be managed. In addition, patients with ischemic DFU usually show worse outcomes in terms of healing, in terms of limb salvage, and in terms of survival. If we think what is the treatment of a patient with ischemic ulcer, we know that all patients with the peripheral arterial disease, but specifically with the critical limb ischemia, need to be revascularized. Regardless the surgical or endovascular approach, the aim of revascularization should be to restore at least one vessel below the ankle for improving blood perfusion in the wound angiosome area. But if it is possible, it's feasible, the wound-related artery should be revascularized to supply directly the anatomical region of the ulcer. But everything even if the theory is easy, the answer is not so easy from a technical point of view, because there are an amount of patients in which revascularization is not feasible and is not possible to overcome the stenosis or the occlusion in the very distal vessel. So revascularization and the unsuccessful revascularization, the failure of revascularization is an old problem, but also a current problem, because revascularization failure probably is the main factor of major, is the most important factor of major amputation in patients with ischemic ulcer. But what means revascularization failure? Revascularization failure means patient with an option critical limb ischemia. And today we know that the patient with an option critical limb threatening ischemia have a name and a surname. They are more or less the 20% of patients that have unsuccessful revascularization, including total unsuccessful revascularization or partial unsuccessful revascularization. They are usually characterized by a very important aggressive atherosclerotic disease with the location of plaque, atherosclerotic plaque in different vessels along the vascular tree. But the most important concept is that the majority of patients, more than 80% of patients, have an ultra-distal location, including the vessel below the ankle. And in addition, this kind of patient, in more or less 30% of cases, at the risk of major, have a 30% of risk of major amputation at 1 year of follow-up. The other important problem in patients with diabetes is the presence, in many cases, of the small artery disease. Small artery disease is responsible of the distribution failure of the fluid belong inside the foot and across the different angiosome area. If you see this picture, you can see that in the left picture, there is a normal presence of small arteries. Otherwise, if you see that the right picture, you can see the absence of a small artery, including digital artery, metatarsal arteries, tarsal, and the calcaneal branch, that sometimes also in case of technical successful revascularization below the ankle, don't allow a good network for improving an adequate blood perfusion in the wound angiosome. But we know also that from a clinical and healthcare point of view, the revascularization failure, the absence of the fluid in the wound angiosome area may be a big problem for achieving wound healing and for improving healing time, and sometimes we have to recur to major amputation. So the problem is also for the scientific community. And among the further question, the further research, one of the most important points is that we have to think, even if there are not so strong studies about, one of the most important points is to evaluate the regenerative therapy for patients with no option critical limb ischemia or not candidate for standard revascularization for improving outcomes. And the regenerative therapy should be related to the opportunity for improving angiogenesis into the foot and to answer to the question of the small artery disease. But what about regenerative therapy, the regenerative cell therapy in patients with no option critical limb ischemia? Even if the studies are not so strong, probably until now, we know that cell therapy, specifically peripheral blood mononuclear cell therapy, or in some cases, mononuclear cell therapy coming from the bone marrow, seems to modify the natural history of patients with untraceable critical limb ischemia, because it allows to improve the ischemic parameters such as TCPO2, pain reduction, and at the same time improving the clinical outcomes, including healing, time of healing, amputation, and survival. And why cell therapy may be so useful, could be so useful for patients with an option critical limb ischemia and small artery disease? Because cell therapy has documented both in laboratory, from a biological point of view, but also in the clinical scenario, that has the ability to create new collateral vessel, remodeling the vascular network by and paracrine activity that is being performed directly in the site of injection. The Italian school in the last year was the more active school in the development of clinical trial, retrospective and sometimes prospective, from the usefulness, the effectiveness of cell therapy in patients with no option critical limb ischemia. And also our group of research in the Tor Vergata University performed some studies about the effectiveness of peripheral blood mononuclear cells in this kind of patient. In this study, we evaluated the outcomes of patients treated by autologous cell therapy in the case of ischemic DFU and option foot critical ischemia with the absence of any vessel below the ankle. The study was a prospective, non-controlled clinical trial, including, of course, patients with ischemic and neuroischemic DFU and no option critical limb ischemia. It has been developed in a single center University Hospital of Tor Vergata in Rome, with the enrollment performed between March 29 and January 22. After the treatment, patients were followed for 1 year of follow-up. If you see the inclusion criteria and exclusion criteria, we included any patient with ischemic or neuroischemic ulcer, but with unsuccessful revascularization below the ankle, so a condition of desert foot, or in the case of the absence of direct fluid to the wound angiosome area and the residual wound angiosome ischemia, defined by TCPO2 levels less than 30 millimeters of mercury. Of course, we excluded patients with the primary indication for major amputation because there was no space for surgical approach for maintaining a good biomechanical foot. Just for understanding the kind of patient that we included in the study, you can see in the case of good revascularization below the ankle, the patient was, of course, excluded. In the case of totally desert foot without any vessel from the dorsal side and the plantar side of the foot, the patient was included in the study. And in the case of one vessel below the ankle, but persistence of wound angiosome ischemia and TCPO2 values less than 30 millimeters of mercury, the patient was at the same time included in the study. All patients received the evaluation of oxygen, of local oxygen perfusion before the injection of autologous cell therapy and after the final treatment. Also, pain using numerical anti-scan was evaluated before the treatment and after the last treatment. All patients received 3 cycles of cell therapy treatment, more or less every 3 weeks. And after the treatment, according to each clinical condition, patients were treated by surgical curative approach, secondary intention wound care, or conservative therapy, or major amputation if there is no space for limb salvage. For better understand, we can see how was the approach, the injection of autologous cell therapy in patients with absence of fluid below the ankle. As you can see in this picture, the approach was in the respect of angiosome concept, and the aim of the treatment was reconstruct the missing artery that usually allows the blood supply in the wound angiosome area. The injection of autologous cell therapies was performed at the distance of 1.5 to 2 centimeters below, between any points, with the aim to recreate small collateral vessels, small arteries that can go to the wound angiosome area. The primary outcomes of the study was to evaluate the rate of healing, amputation, and survival after 1 year of follow-up. As a secondary outcomes, we evaluate the improvement of ischemic values by TCPO2 evaluation and the improvement of foot pain. We included 55 patients with a mean age of 75 years. The prevalence with the majority of the patients were male, with the prevalence of type 2 of diabetes, and the mean diabetes duration of 22 years. As you can see, they reported several comorbidities, particularly 7% of the patients had end-stage renal disease, and 85% had a chronic ischemic heart disease. If we focus on the characteristics of ulceration, you can see that the majority had an involvement, at the bone involvement, more or less 65%. At the baseline, at the first hospitalization, 81% of the patient, 82% of the patient had an infection, 50% had an osteomyelitis, and 89% had the gangrene, requiring the demolitive surgery in the case of surgical curative treatment, and 23% of the patient had an ill location of ulceration. What about outcomes? 69% of the patient healed and survived after 1 year of follow-up, 3.6% of the patient healed but deceased, 10.9% healed but deceased, not healed and deceased, and 6.4% of the patient not healed and received major amputation. What are the rate if we focus on the rate of amputation? What is our impression about the results? If we compare it with the mechanical revascularization, we are not so happy about the results, but we remember that we are speaking about no option critical ischemia patient. But if we compare this data with the patient that we treated some year before by conventional therapy without cell therapy, we find that 30% of patients that were treated by conventional therapy received major amputation. So even if the comparison is not direct, is not in the same study, we found indirectly a reduction of 50% of major amputation in patients treated by a regenerative therapy. We found also an improvement of foot perfusion, starting from 70 millimeters of mercury before the treatment to 41 millimeters of mercury after the treatment. At the same time, a significant reduction of pain by numerical rating scale from 6.8 at the baseline to 2.8 after the treatment. Here you can see some cases of some clinical cases, a patient with the gangrene of the second two, without any vessel from the tarsal area, the base of the metatarsal area. Here you can see after regenerative therapy, we performed the surgical curative treatment with amputation of the second two at total healing. Another patient with no vessel from the metatarsal area to the digital and the digital arteries. We performed a negative transmetatarsal amputation at total healing, complete wound healing. Another patient with a gangrene of the first ray without any vessel in the dorsal side, but also in the plantar side. So a condition of total desert foot treated with regenerative therapy. You can see a complete healing after vascularization. It's very interesting also to see in this angiography that we perform by chance after the treatment an improvement of collateral of small arteries in the site of wound angiosome area. Here another patient that we can see the treatment, the condition before the treatment and the results after the treatment, and another case where we perform by chance an angiography and we find a very important new vascular tree in the area of the treatment. So after the first study, we perform also a new study that we can call post-hoc analysis studies, in which we evaluate the effectiveness of autologous mononuclear cell therapies as adjuvant therapy for patients with receiving indirect lower limb revascularization. As you can see in the study, we included patients with unsuccessful direct revascularization below the ankle with the persistence of ischemia in the wound angiosome area. patient required at least the presence of one vessel below the ankle, but they had the absence of collateral vessel at the final angiogram evaluation, so a condition of small artery disease, and the TCPO2 values level 30 millimeters of mercury in the wound angiosome area. You can see here some clinical picture of the patient that we included. So patient with a gangrene in the heel without any vessel in the hind foot. Another patient with a gangrene in the forefoot and the midfoot and the dorsal area of the midfoot with a good revascularization in the plantar side, but without any vessel in the dorsal side. So a persistent of wound ischemia in the anatomical region of the ulceration. In this study, we included 52 patients with a mean age of 73 years, with the same more or less diabetes duration, nearly to 20 years. Again, the majority of the patients had a chronic ischemic heart disease, more or less 80%, 100% had the gangrene, and 76% had an infection at the baseline. To better understand the characteristics, the severity of ulcer, you can see that more or less 56% reported in a 3D Texas University classification. What about outcomes in this particularly subgroup of patients? 84.6% of patients reported total healing, complete healing at 1 year of follow-up, and no patient had major amputation at 1 year of follow-up. Of course, this kind of patient had a less severe case, a less severe condition in comparison to patients with a total condition of desert foot. Then, in addition to our local study, our local clinical experience, recently have been published an interesting meta-analysis systematic review about to assess the efficacy and safety of autologous cell therapy in patients with ischemic diabetic foot ulceration and no option critical limb ischemia, performed by the panel of authors that are now involved in the development of Italian guidelines for the treatment of diabetic foot. And if we focus only on the most important result, they reported that the patient treated by regenerative therapy reported more chance of healing in comparison to patients treated by conventional therapy, with the results that are better more than 10 times in comparison to the control group. The same result, more or less, are reported when the measure amputation was evaluated. Patients treated with regenerative therapy reported a reduction amputation rate in comparison to patients treated by conventional therapy. So finally, after the different study that we have in literature, after the first experience that we have in the last decade, probably, we can say that regenerative autologous cell therapy could be, or is, I think, a good option for treating patients with no option critical limb ischemia. And the results that are more or less linear with the different study report a reduction of 50% of major amputation when compared to patients treated by conventional therapy. Cell therapy, autologous cell therapy, could be also an adjuvant therapy for patients that receive indirect revascularization and maintaining or that report a condition of residual wound angiosome ischemia. And of course, further studies are useful to identify what patients are suitable, what are the predictor factors of successful treatment with regenerative therapy or unsuccessful therapy. Thank you very much for your attention.
Thank you, Dr. Maloney, for your insightful presentation. I think it's a very, very promising therapy that can get another extra option for people where the only indication they have the amputation. I think it's a very, very nice option to consider. So we had a brief question, two brief questions to you. So one is concerning the comparison about the use of the stem cells with this new therapy. Is there any comparing with this therapy? Is there any advantage? Is something that is working better? So what is your opinion about this?
Thank you for the question. Unfortunately, there is no studies that report the comparison between autologous cell therapy performed by mononuclear cells and stem cell. I think that today we have probably more robust evidence from mononuclear cell therapy than stem cells. Of course, we need a further study from on one side, on the other side, to better understand where one of the two therapy can work better, or what are the patients suitable for the treatment. But of course, we have no data, no evidence to indicate what is the best therapy for this kind of patients.
Mm-hmm. Okay, thank you. So another question concerning, you saw it in your series, that of course in the intervention for the patient after the injection of this therapy, you performed some surgical debridement. So toe amputation, so soft tissue debridement. So how long time did you wait for taking the decision to put the patient in the operating room?
Usually, if the clinical condition is stable, we perform after the third cycle, we reevaluate the patient after 2-4 weeks, more or less, and we perform TCPO2 evaluation to understand what is the local perfusion and how we can move from a surgical point of view. So usually between every treatment, we didn't perform any surgical approach, any debridement, if we don't have any concomitant infection, or if there is a progression of the ischemic condition. Because as you can see in the baseline characteristics, the majority of patients have a condition of gangrene. So gangrene can be located in the apex of the toe, can involve the toe, or can involve the ray or the heel. So we usually wait the maximum effect of regenerative therapy, and only after the last treatment we decided to perform or no the surgical approach. But no surgical approach during the treatment.
Mm-hmm. Clear. So thank you very much again. So unfortunately, we don't have enough time for asking more questions. I'm going to introduce the last speaker that are joining us from US. So I think that I can say I can spend half an hour to introduce Professor David Armstrong about his curriculum. I can say 3 or 4 words about him. So Professor Armstrong is the top ranking researcher in diabetes food. So he has more than 700 peer-reviewed manuscripts in the literature. So that thing that is this data is talking isolate about who is Dr. Armstrong. Additionally, Professor Armstrong is professor of surgery in the University of Southern California. He is a top key opinion leader in diabetes food for many years ago. Thank you so much, Dr. Armstrong, for joining us. I know that you are very busy today, and thank you for joining this webinar, and now the floor is yours.
David, you're welcome, and thank you again.
Absolutely, positively, both Luigi and Jose Luis. I just saw you on Monday, Jose Luis, and we saw Chris, Manu, and of course, Professor Edmonds from King's. What a great group. But listen, I'm going to hurry. What do we have? 15, 20 minutes? 15 minutes? 15? What do you think?
It's around 20 minutes.
Good. I will hurry so I don't make everyone else bored. And then I'm going to run to go see a patient right after this. How does that sound? So, and that's exactly what we're talking about. Professor Jose Luis asked me to write about or talk about what happens when podiatry is removed, but really use that as a context for describing how to put teams together. That's exactly what I'm going to talk about. We give all of our slides away. Just please email me or ping me, and we ask you to copy them and make them better. That's the big idea. You've already heard a bunch of people that are smarter than I am already talking about this in these great talks that have preceded mine. This analogy is often made, the foot being compared to cancer. We've made this over many years, and it's not fair to compare one terrible thing to another. But the fact of the matter is that if we just look at mortality, These data have been widely, reprinted. You see that it really is comparable. These problems that we see, foot ulcers, limb-sparing amputations, CLTI, and major amputations are at least as bad as a bad form of cancer. You already heard Professor Buss talking about diabetic foot ulcers and their recurrence in that spectacular talk on shoes and offloading. He talked about the fact that these wounds, after we heal them, return at about 40% at 1 year, 2/3 at 3, 3/4 at 5. So recurrence is not only common, it's likely. And so if the foot in diabetes is a little bit like cancer, then when it's healed, maybe it's not healed, maybe it's in remission. And this sounds just like we're playing with words, but I assure you that it really is important, because when you talk to your patient in this manner, understanding that it's almost certain that the wound is going to recur, then your relationship with her and with him changes, because you know that that person you're going to be with that person for their whole life. That from the alpha to the omega, and that's much bigger than just a short, sharp shock in the operating room, or one quick visit, or writing them a prescription. And I'm going to show you these data. You're amongst the first to see this. This is another slide comparing the diabetic foot to cancer and CLTI to cancer. But look at this. This is not mortality. This is recurrence. If you look at recurrence of high grades breast cancer, prostate cancer, lung cancer, colon cancer, and then look at CLTI after reintervention, and then diabetic foot ulcers, remarkably comparable. So the point is, this is a chronic disease model, and these patients are in remission. And in order to do that, it does not just take one individual clinician, no matter how good she or he is. It takes a team, and the good news is that these teams, however you put them together, they seem to reduce amputation. Look at these data. These are really elegant data across the world. We could go to every inhabited continent here at left, and you see net protective effects before and after in reducing high-level amputation. If you look at a recent paper that I did with Professor Buss, but also with Professor Bolton and my vascular surgery partner, Ziwei Tan, you see a 60% relative risk reduction if we look across studies in the literature in any way you put these teams together. So in any way you do it, you're making a difference. But there's probably better ways to do it in different parts of the world than others. So let's talk about the toe. Let's talk about the flow, and then talk about mashing those up, and then 4 steps to success, and then we're going to close. This seems to be true. Foot care seems to prolong the life of the extremity. There's all kinds of data. These data, I leave them in because they're some of the older ones. But if a person just sees their foot doctor along with another member of the team, the relative risk of high-level amputation goes down, I should say, anywhere from just under 20% to about 2/3. And that's astonishing. That's a blockbuster drug if we were talking about something like this. But the fact is that it's even bigger in other studies when you see this sort of thing. But so that's what happens when you add foot care. But what happens when it's removed? And this is what I was asked to talk about many years ago during a financial crisis in the late 2000s. We unfortunately, this happened in one of the states in the United States. It ended up leading to what we call foot in wallet disease, when podiatric care was removed for our most poor patients in the state of Arizona. Let me just show you these data because it's crazy. After it was removed, this is right after the announcement of removal, there was a net increase, look at that, of 37.5% increase in hospital admissions for diabetic foot ulcers. There was a 22.8% increase, as I remember, for length of stay, 45% increase in the cost, the charges per patient, and for what we call severe aggregate outcomes, which is a euphemism for sepsis, amputation, and death. That increased by just under, I think it was 50%, just under 50%, 49.5%. So these people's feet, when you took podiatry away, really were killing them. They were not going to another doctor. They were going to the emergency department. And then they were getting admitted, and then parts of their body were being removed. That's what happened. And then when it was reinstated, good things started to happen. It started to return. Look at this study that just was published by my partner, Ziwei Tan. It's a great project where he looked at the same patient population after podiatry was added and expanded across the United States. There was a net reduction in high-level amputation for this patient population by a third in the highest risk patients. If you were a minority population, if you were a person of color, if you were Black, Hispanic, Latino, or if you were Native American. So the more you need it, the better it works. That is pretty great. So that's what happens when you add podiatry. It seems to prolong the life of the leg, and when you remove it, bad things happen. But look at this. These data are seem to be true when you revascularize people and you look after the flow, you prolong life itself. These are just classic study from the late great Ennio Faglia from Milano, slightly north of Roma and Tor Vergata, but really from the same great group of investigators across the Italian peninsula. And you see here, it does not matter whether you are an open or an endo enthusiast, good things happen when you look after the flow. There's a net protective effect on mortality. And this has been repeated as well in many other studies. So the first point was putting the toe together, then the flow together. Maybe you can mash these things together and make a team that might be helpful in mitigating amputation and maybe helping people live longer. And that's called in the United States, we call this the toe and flow model, but it's now taking off all over the world. But you can kind of be agnostic about the specialty, but you can be evangelical about the skill set. And we have two surgical specialties on one service. In this case, it's podiatric and vascular surgery. And then we surround it with all the other members of the team, with the patient at the center. And we have one hotline, if you will, for clinicians to call from the emergency department or on the hospital wards. And that hotline is called a hot foot line. And when you incorporate this hot foot line, good things seem to happen. It's really easy to understand. If someone's in the emergency department or the A&E, to translate if you're British, or on the wards, and it's a wound in someone with diabetes on their lower extremity, then this hot foot line is engaged. And we ask, is this an infection or is this ischemia? Is it infection dominant or ischemia dominant? And this determines who the admitting clinician is within the team, but everyone's seeing them on the team. And these people, the people who are referring, don't have to worry about all the triage because it happens internally. And that really has been helpful. Let me just show you these data. These are already more than a decade old. The bottom line is, even for a team that cared about diabetic foot care beforehand, when they added this sort of model, there was a net reduction in high-level amputation, just like you saw in those other studies. And there was an increase in vascular surgery volume, and there was a dramatic change away from just cutting legs off and cutting feet off to doing more reconstructive work. That was a dramatic change. And this also happened here locally in one of our county hospitals at Rancho Los Amigos, actually where Bill Wagner used to work. We now have a limb preservation unit led by Ziwei Tan and Tanzim Khan. And you see this same kind of net protective effect here with big reductions in major amputation, but increases in outpatient reconstructive procedures and increases in revascularizations, concurrent with a single specialty clinic even that was continuing to go on for the last 50 years at the same time in that hospital. So that's how you build a team. How do you putting the toe and flow together, but how do you build a program? Now we're going to talk about 4 steps to success. And the good news is we've already talked about one of those steps. So you're already ahead of the game. And so the 4 steps include the hot foot line, like we talked about, moving when they leave the hospital, they go to a wound clinic. When they're healed, they're not healed. Like we said, they're in remission. And then we have a larger screening program where we can drive people in to the rest of this program, depending on their risk stratum with just a 3-minute foot exam. We already talked about the hot foot line, didn't we? Already, but the measurable goals are not only length of stay, but also a high amputation ratio to a low amputation ratio. If we believe that most limb-sparing amputations in the foot are better functionally than a high-level amputation, in most cases, not in every case for sure, then that's your beginning of your discussion. Then when someone is discharged from the hospital, they're discharged into a wound clinic, a tissue loss clinic where they have active tissue loss. And what is happening in this patient now is that the goal is to try to get that person healed as rapidly as possible. And these are our measurable goals here, which we can derive from the hospital records, or you can have a QA person doing this yourself, no matter where you are in the world, no matter what health ministry you're in. Then when people are healed, when you get them to closure, remember, they're not healed, they're in remission. And the goal here is to start dosing that activity. And you heard those great discussions with Sickle Bus and Jose Luis about how you dose activity. And we dose activity by checking skin temperature, just like people would dose their insulin by checking glucose. And everyone's a little different when we do this, but that's our big idea for treating these patients. And we have ulcer-free days, just like you heard, hospital-free days, activity-rich days, as well as trying to keep any kind of amputation limb sparing. And then finally, the screening clinics. We can do a 3-minute foot exam and then triage people into low, moderate, high risk or in remission, and then even active problems really, really rapidly. This has been validated now any number of times. And you see these measurable goals that are similar, but for an entire population, if you're doing this in a screening sense, from a primary care regime or even from a health fair, and whatever you're doing. It doesn't matter who's doing this. What matters is that it's being done. And so those are the 4 steps to success. And what's pretty great in the United States is because in the past, what we found was there were not a lot of clinicians. There were a lot of clinicians that cared about this, but there was no way to get them together with patients and kind of figure out how to build teams. And so what we did was we built this American Limb Preservation Society. Let me tell you, you are so welcome to join. Anyone joins. We have people from all over the world. It's only started in 2020 during the pandemic, and now there are over 1,000 people in it. I can't believe it. It's so life affirming. And this is, I know it's just another organization, but this is really simple. It's just a cross between a dating app and a marriage counselor for clinicians that care about this problem. That's what it's at. Dating app, marriage counselor. And it puts people together and hopefully keeps them together. That's it. That's its only pretension in the most humble sense of the word. If you guys are interested, you're so welcome. I think you could join for free. It's just, I think still, I'm not sure. I think there are always these special offers, but you're very, very welcome to join. It's really life-affirming stuff. And Mr. Chair, ladies and gents, I put this video in at the last minute because I was talking to my my daughter this morning, and she's on her way here to see us for the holidays. Our middle daughter, and she's in this video. You know, this is like 20 years old. You know, if you go to France, not to Italy, not to Don Luigi's country, but maybe to France, you'll go to Paris. If you go to Paris, you have to see the Louvre. See the Louvre after you see Notre Dame, of course, in its glory. You have to go to the Denon room. Back in the day, you used to see the Italian masters. And look at this. When I went, it was like every other day. Huge crowd, like a rugby scrum. And check this out. You see this little disappointing masterpiece, nonetheless, but way in the distance, and you can't even get to it because there's so many people. And my daughter was the only one that was looking around. She was not impressed, but she was impressed because she took a look around, and look at this feet, a masterpiece, but no less a masterpiece than La Joconde, Mona Lisa, but often overlooked. And that really is what we're talking about. And sometimes it takes the observation of a little kid to be able to see this and step back and know that we can hopefully make a difference. And for this problem that we're dealing with, it's no less a masterpiece than the rest of the body, but it's often 11th on everyone's 10 most important things. And our goal is just to keep it that way, but to keep it on and keep people moving through the world in the most humble way and help them navigate through their world. And I think that's worth a life's work. And ladies and gentlemen, I thank you so very, very much. It's such an honor and pleasure to be with you guys here, even on a busy Friday before the holidays. And I wish you the happiest, healthiest holidays. And 2025, here's to making a difference and paying it forward.
Hi, David. In Italy, we say that good blood says always the truth. This is the case. So I can imagine that we will have a fantastic scientist in near future. So
Oh, she already is. By the way, Luigi, she's actually, I forgot to tell you, the oldest is a third-generation foot doctor, Jose Luis.
I know, I know her very well.
I know you know her. The middle one is at, she's at the National Academy of Sciences at Hopkins now. It's crazy.
So it's art, not science, but
That's right. I agree with you.
Anyway, so thank you for your fantastic talk. And there are some questions about your opinion with the infrared way to take evaluate neuropathy and peripheral artery disease.
Yeah.
And the role of this technique with the podiatrist and the podologist.
Yeah, happy to talk about it. So, in fact, right after I talk to you, actually, that's not true. After I have to see one patient now in the operating room, and then my first patient I'm seeing post-operatively, right? This person now is going to be in remission now with a closed wound here at 9:30 a.m. I'm seeing them in the clinic right across the way here. And so what I'm going to do is I'm going to see him, and I'm going to say, Mr. X, his name isn't Mr. X, although he would respond pretty well if I told him that. Mr. X, you have this wound's healed, you're not healed, you're in remission. Now our goal is to help you dose activity, and we will give him a little something and say, hey, go onto Amazon, and I want you to just spend $10 US on one of these on one of these infrared thermometers. If they don't have very much money, they can get it for $10. And then we have them print out a little, we give them on our blog. It's really easy. They just print out a little map, and then they could start mapping their skin temperature, just like people 30, 40 years ago used to map their blood glucose, right? No one does that anymore, but this is the way to do it if you have only $10 to spend for a patient, or if we can't get it for free. If people are wealthy, then we will have them maybe go to one of these companies that have things like a bath mat that you can step on, or even insoles that people can subscribe to. And then these can identify hotspots, and we have them dose their activity, because everyone, rich and poor, all have phones, and we have them use their phone, or we have them use their, if they have a smartwatch, we have them dose their activity by checking their skin temperature, just like they dose their insulin by checking their glucose. That's the idea. If they get out of range, and we use data from a study we did in the mid-2000s in diabetes care, where we look at kind of, it's like an M value, Luigi, if you're doing as an endocrinologist, we look for an excursion. And if you go beyond that excursion, it's like a peak. And we tell them, well, you got to back off of that, and you got to ease yourself up to that peak. And it's so easy. It is on an Excel spreadsheet. And you hear what Seco is doing now. And I think what Seco is doing is even better. I mean, it's just so elegant. But this is what we do with our patients, and their activities are very different depending on their their lifestyle, if they have to look after some kids or grandkids, if they have 2 jobs or 1 job, or if they're retired. And we have our physical therapists, or to translate for Britain, physiotherapists, look after these patients and dose them back to activity. Actually, I have JT, one of my physical therapists, and Stephanie Wolfel with me today, and they're way better than I am. So we call that, and I'll shut up after this, we don't call it toe and flow. We call it toe, flow, and then with physical therapy, we call it and go. Toe, flow, and go.
David, what is your opinion about the multi-sensors in souls?
Okay. Well, I think I'm excited about them, actually, but I have been, Luigi, I have been enthusiastic about these for 30 years. So, but I believe strongly that these devices are now getting better and better and more personalized. And I see Marcos was talking about AI-driven solutions. But oh yeah, look at that! I got to look at this. What he's writing here about, but we're actually applying kind of AI-based Sherpas to some of these things to map out the bottom of the foot with kind of poly sensor insoles. We have a study that I believe has been, I think it's been approved but not funded yet by our United States National Institutes of Health, called the Wired Up study, where we're going to be giving people smart insoles and have them go out. These are people in remission, and we're going to really, with a really fine kind of algorithm, sort of try to dose their activity and predict recurrent ulcerations.
And do you think that we can solve the problem of the absence of limit in the load that we can determine for our patients?
Yeah, absolutely. I believe this is true, and I think Dr. Hafiz was talking about plantar pressure mapping devices as well. We use these, and many of these insoles now also have pressure capacitors in them over many years. And yeah, I believe that now, hopefully, if we can figure out a way, or for these companies to make money on this, or if we can figure out a way for health ministries at the same time on the other end around the world to just focus on this a little bit, then I think and this is happening much more than at any time in my career. I think that we're going to be making a difference. But the key is just to keep on pushing and to stay, like the politicians say, stay on message. And you really just have to stay on message, even though you, Luigi, you, Jose Luis, or Marco, or any of the guys on here have I see, Dragana, you probably said the same thing to people and to health ministries 1,000 times, and you've seen them nod their head. But I think staying on this is the way forward. And I'm more enthusiastic than I ever have been, because I'm starting to see companies who are in the business to make money. And maybe I think they may secondarily want to make a difference, but they're companies first and foremost. These people now are paying for better offloading. Now, these are people that make these biologic dressings. In fact, I just saw the first at DEF CON do this. They're paying for some of the offloading devices, and they are paying for some of the monitoring on these patients, because they know that it's only a little bit of money on top of whatever it costs, how many thousands of dollars for this product that they're using. And now the patient is less likely to destroy it when they walk out of the clinic. And that's the first time that I've ever seen that kind of combination of biologic marrying completely with a prosthetic company, and just paying for it. So I think that kind of thing might happen, along with remote monitoring.
Another question: in considering the role of rigidity of the foot in the evolution of neuropathy, what do you think that physical activity and rehabilitation specialist has an important role and place in the team from the beginning?
Yeah, that's wonderful. A wonderful question. I think that, again, we talked about our team, we call it toe, flow, and go, the go portion for physical therapy. And also, I didn't mention occupational therapy, who help our patients modify their jobs and help them with behavioral health, believe it or not. But also, physicians there are what are called physiatrists, or physical medicine physicians in the United States, and some of them exist in other places, and they are spectacular. And there have been really successful limb preservation units over the last half century that have been developed with those physicians at the core, looking at motion and moving people and measuring what they manage. And that has been a really great way forward. And you heard Siko talking about kind of measuring cumulative plantar load in patients. And that is something that has been done now by PT, by guys like Cinecor and Mueller and friends of ours over a long time. but he's really doing it and measuring it. And I think having clinics that have that as a first principle, along with good flow doctors and toe doctors, is going to succeed even more.
Okay, thank you very much. Thank you. Now,
Thank you, David.
okay, I'm going to summarize our webinar and closing it. So we had the occasion to have a very high level webinar with the fantastic speakers, starting from Sico Buzz that showed us the role of offloading and the role of the shoe and the physical activity, and the next step in allowing our patients to have not only physical activity, but certain different level of sports. I think this is a really a new area in which we have to perform, because we know that our patients need to have physical activity, but as we say, they need to have a protected physical activity in order to avoid the development of a new ulcer of relapses. The contribution from venue is fantastic, according to the role that may have the Charcot foot in risk of amputation. And the cases that he presented are very, very impressive, and show us that it's possible in many cases that we used to amputee in the past, that there is a way to save the limb with both the system with the intramedullary or external fixation. Also the option that he showed us in a few cases to perform this kind of intervention in patients with acute Charcot is a new area in which we must probably work a lot, because if we can help from the beginning our patients, probably we can help them better. The data presented by Dr. Meloni are very interesting in the way we have now new options for what we say no option patients with vascular disease, in which there is no way to treat, and the results are very promising, because it's a new way to approach those patients, mainly very, very sick, mainly with a lot of comorbidities. And we know that we can save a limb. In many cases, we can save a life, because we know that those patients, when they are amputee, are also close to end their life. And finally, the contribution by David Armstrong, that is always fantastic in showing us how it is important to consider our patients at life, because the diabetic foot is a disease in which there is no healing, but there is a remittance. And the important information that always we need to work all together in a team, because no one of us is able to know everything about food. So we need to have a good thing, a big thing, and this is the only way to get results. So in this way, I like to close this webinar, and I keep the occasion to give to all of you my best wishes for Christmas and for the new year. And we hope that this nice occasion, and for this I want to thank JCM for organization and hospitality. We will have another occasion, perhaps in 6 months, to have a new and nice webinar like this. So thank you for all speakers, thank you for all participants. And again, have a nice Christmas, a fantastic Christmas, and Happy New Year. Bye-bye.
Bye-bye. Thank you
Ciao,
to
ciao.
everyone.
Bye-bye.
That's awesome.
Bye bye. Thank you all.